this private practice. So over to you, Dr. Ashutosh.
Thank you, sir. Thank you for your kind words. Good morning again to all the respected seniors, colleagues, and friends. Now we are going to discuss on recent updates on asthma. I am touching the basics of asthma. It is important for all of us, for all the practitioners, despite of any specialty. We all know that Gina suggests that the initial diagnosis of asthma should be based on the characteristic pattern of respiratory symptoms such as wheezing, dyspnea, chest tightness, or cough. Main thing in asthma is the variability. There is symptom of variability such as worsening during night or an exposure to triggers. Triggers can be anyone, can be emotional stimuli, can be pollens, can be dust, can be fumes. And there is variable expiratory airflow limitations. Means when there is inability to empty your lungs out completely during exhalation. Spirometry is the main thing to diagnose the asthma and its severity. It is maybe easily accessible and may not be easily accessible, but it's quite available in our city. We all are doing spirometry. Gina also recommends that if spirometry is not available, peak flowmetry is less reliable than spirometry, but it is better to measure PEF than relying on symptoms alone for diagnosis. A simple case, a 25-year-old male presented with dyspnea and cough for 4 years in OPD. Dyspnea associated with wheezing and seasonal variation and remissions. Sometimes symptoms occur, sometimes disappear, then recurs. He is non-smoker with no relevant occupational exposure, associated with sneezing and rhinorrhea. Examination revealed prolonged expiration, or we can say harsh vesicular breathing. Sometimes wheezing is not present on every asthmatic patient. Hemogram is normal. Eosinophilia is almost normal up to 7, higher side to 7%. Serum Ig level is 223, slightly higher. Blood chemistry and chest radiograph are normal. He was underwent spirometry. You can say there is classic of spirometry. When you see this type of presentation, this is respiratory limb, inspiratory limb. When it is the graph before giving bronchodilator, this is the graph after giving the bronchodilator, salbutamol inhalation. This is the classic of asthma. Double graph is classic of asthma. You can easily assess there is grass improvement after giving bronchodilator. So initial FE1 is 64% and FEC is 76%. But after giving bronchodilator, it is about 30% improvement in the FE1. It is significant. If there is more than 12% improvement or more than 200 ml improvement in FE1 or FEC, it is called significant. The shape of the flow volume loop shows a concavity suggestive of airflow obstruction. The post-bronchodilator loop is bigger, suggesting a response to bronchodilator. FE1-FEC ratio is reduced, confirming airway obstruction. Post-bronchodilator increase in FEC and FE1 is more than 12% and 200 ml. So what is the interpretation? Interpretation is moderately severe airflow obstruction with significant response to bronchodilator. We can diagnose this bronchial asthma based on history and spiral. This classic presentation of asthma patient. What should be our goal to treatment of the asthma? There is some long-term goal. Long-term goal is should be no or few symptoms and symptoms and to quickly relieve to it. No sleep disturbances and unimpaired physical activity is very important. All asthmatic patients, all COPD should be assessed for physical activity. Most of the patients not going to do physical activity. We should always ask them to do any type of physical activity. Walking, some cardiac exercise, some cycling, they should be promoted. And there is long-term asthma risk management, which may include there should be no exacerbation, improved or stable personal-based lung function, no requirement for maintenance oral corticosteroid. Oral corticosteroid डोज जितनी कम रख सके, जितना कम यूज करना पड़े उतना अच्छा है. No medication side effect. When discussing best possible long-term outcome with the patient, we should also consider some other factors like their asthma phenotype, their clinical features, their multi-morbidity, patient is obese or not, any other comorbidity, any diabetes, hypertension, LVF, CAD, risk factor. There should be poor adherence. Smoking history is very important. There is personal persistent airflow limitation or not. Availability is very important. Availability of medication, cost of medication, and adverse effect of medication. ऐसी दवाई लेनी जो बहुत महंगी है, पेशेंट ले नहीं सकता, क्या फायदा लेने? द पेशेंट्स गोल, पेशेंट का अपना गोल क्या है, वो क्या चाहता है, ये बहुत जरूरी है. देयर मे बी डिफरेंट फ्रॉम मेडिकल गोल. जो हम चाहते हैं हो सकता है वो जो चाहता है, देयर शुड बी different. There may be a difference. So we should act according to the patient condition also. We should assess asthma like we should confirm the diagnosis if necessary, symptom control and modifiable risk factor. And we should also take call on comorbidities. We should also take inherent technique and adherence and patient preference and goal. Then we have to adjust treatment of modifiable risk factors and comorbidities. Non-pharmacological strategies, asthma medication including ICS, education, skill training, or action plan. And we should again review about symptom of the patient, exacerbation history, side effect of the medication, lung function, other comorbid, and patient satisfaction. So there are step-wise approach according to GINA for management asthma and according to severity of the patient. Step 1, step 2, step 3, step 4, and step 5. There are two tracks, track 1 and track 2. Basically, we are stick on the track 1 medication. It is preferred also. Single inhaler for this track 1, preferred control and reliever medication. It includes ICS formoterol as a reliever. It is long-acting beta-2 agonist, formoterol, and the reliever reduce the exacerbation compared with only SABA. SABA means short-acting beta-2 agonist like salbutamol or salbutamol, and is a simpler regimen. Initially, we are using SOS, low-dose ICS formoterol. Earlier, we are using salbutamol inhaler or leosalbutamol inhaler. But now, guidelines say we have to use combination, basically. ICS and formoterol combination. ICS means inhaled corticosteroid. Inhaled corticosteroid, most commonly budesonide and formoterol combination. Step 1, as needed. जरूरत है सांस फूलने तो दिया, तो नहीं दिया. Step 3, when there is persistent of symptom, we have to use low-dose maintenance ICS and formoterol twice daily regime. Step 3. In step 4, we can increase the dose of inhaled corticosteroid and formoterol. And step 5, the patient is still not maintaining his symptom, still there is persistent of airflow limitation, we can add LAMA. LAMA means long-acting muscarinic antagonist like tiotropium bromide or glycopyrronium, and can also assess for phenotype. Consider can add high dose of maintenance inhaled corticosteroid formoterol, or we can add anti-Ig therapy or anti-IL-5 biologicals, or long-term oral corticosteroid if patient is still not relieved with these combinations. Track 2 is less preferred. It takes that we have to use inhaled corticosteroid alone along with salbutamol or leosalbutamol as a SOS basis. But this is not preferred regimen. We are already preferring track 1 only regimen. GINA is a fundamental change in asthma management. It said the treatment of asthma with short-acting bronchodilators like leosalbutamol, salbutamol alone is no longer recommended for adults and adolescents. So why not? We should not use salbutamol alone, because SABA treat the symptom only, not treat the disease. People with apparently mild asthma can have severe or fatal exacerbation. Regular use of SABA or short-acting beta-2 agonist, even for 1 to 2 weeks, associated with increased airway hyperreactivity, it can reduce bronchodilator effect and increase allergic response and increase eosinophil also. Starting treatment with SABA alone tells the patient to regard it as their primary asthma treatment. Poor adherence with ICS is almost inevitable. ऐसा देखा था किसी को आपने स्थलीय इनहेलर लिख दिया तो लेते ही तुरंत आराम मिल जाता है. वो क्या होता है, उसे वही लेता रहता है, बाकी दवाइयां छोड़ देता है. तो हम लोग कोशिश स्थलीय उसको देना ही नहीं है, उसको कॉम्बिनेशन ड्रग ही देनी है ताकि वो प्रॉपर ट्रीटमेंट ले. There is strong evidence for a more effective and safer alternative than SABA alone, or ICS plus as-needed SABA, or as-needed ICS formoterol. When compared to as-needed SABA, the risk of severe exacerbation reduced by 60 to 64% when you are using in combination. Compared with maintenance low-dose ICS plus as-needed SABA, risk of severe exacerbation are lower. No clinically important difference in symptom control or FE1. Patient used as-needed inhaler on 30% of days, very low ICS dose. Outcome of severe exacerbation, asthma quality questionnaire were independent of baseline characteristics, including blood eosinophilia, FeNO. FeNO means fraction of expired nitric oxide level, lung function, history of exacerbation. Embedded qualitative research demonstrated most patients preferred as needed combination treatment over regular daily treatment. Same, as needed ICS formoterol is better. MART means single inhaler used for maintenance and reliever treatment with ICS formoterol reduce the risk of severe exacerbation requiring oral corticosteroid compared with other regimen plus SABA reliever. It is not just an anti-inflammatory drug. Formoterol acts as a reliever, reduces risk of severe exacerbation compared with SABA reliever, but greater reduction if as the reliever in ICS formoterol. MART means maintenance and reliever technique is more effective than ICS LABA plus SABA reliever in both eosinophilic and non-eosinophilic asthma. It is used in both phenotypes of asthma. Benefit of MART further increased with higher blood eosinophilia. MART is approved in more than 120 countries. We already discussed step one as needed only low dose ICS formoterol reliever. One inhaler used as needed. Single inhaler used for both. In step three, same inhaler we can take one or twice a day. In step four, same inhaler take two inhalation twice a day or one as needed. And step five, refer for expert assessment. So single inhaler can be used for all the steps. Step one is on a serious basis. Step three on low dose ICS. And step 4, we can increase the dose of same inhaler. It is very cost effective and easily accessible for the patient also. But there is limited combination which are used for MART. One is the most commonly used budesonide and formoterol combination. Adult and adolescent is 200 is for the budesonide and formoterol is 6 microgram on beta dose by DPI or MDI. And for children to 11 years, we can use budesonide 100 microgram and formoterol is 100 microgram, budesonide 100 microgram, and formoterol is 6 microgram by meter to inhaler or dry powder inhalation. We can also use beclomethasone formoterol, but we are much using budesonide and formoterol. It is more effective. Use of higher or lower dose formulation, then this is not recommended. The maximum total dose of formoterol in any one day with any formulation is 72 microgram for adults and adolescents and 48 microgram for children 6 to 11 years. ICS formoterol is the only ICS LABA that can be used as anti-inflammatory reliever. Track 2, it is not preferred, so I am not going to discuss this track 2. If there is, it is very practical approach to, so if there is daily symptom, waking or night, once a week or more and low lung function or recent exacerbation, we have to use medium dose ICS formoterol maintenance and liver medication. If symptom is most of the days are waking at night, once a week or more, or there is low function, we have to use low dose ICS formoterol combination, single inhaler maintenance and reliever. If symptom is less than 3 and 5 days a week with normal lung function or no nighttime waking, we can use only as needed low dose ICS formoterol. We cannot use it regularly. When we step down asthma treatment, ऐसा नहीं कि एक बार दवाई शुरू हुई वही दवाई जिंदगी भर खानी है. We can also consider for stepping down of treatment. We should consider stepping down when symptoms are well controlled and lung function is stable for more than 3 months. If patient has exacerbation risk factor is severe, for example, severe exacerbation in past year, step down only with close supervision. Choose an appropriate time when there is no pollen season. Treat each step as a therapeutic trial. Engage the patient in the process. Document asthma status. Provide clear instructions and an action plan. There should be sufficient medication to resume previous dose. Monitor symptom and PEF. Schedule a follow-up visit. Do not stop ICS content treatment. When we consider stepping down, we should not stop inhaled corticosteroid. We should taper it down. Same slide. Low dose for children 6 to 11 years, same low dose ICS whenever and SABA taken SOS basis. Daily in step 2, we have to use daily low dose ICS. For step 3, we have to use low dose ICS combination or medium dose ICS only with reliever medication. And we can also use nicotine receptor antagonist like Montelukast in step 3. For step 4, we can use medium dose ICS LABA or low dose ICS maintenance therapy and add tiotropium. Tiotropium is LABA or nicotine receptor antagonist in step 4. In step 5, we should use higher dose ICS LABA combination or we should also use Biologicals are anti-Ig therapy, anti-IL-4 or anti-IL-5. At last start, consider add-on. If there is still not symptom are not controlled, we can use low dose oral corticosteroids in the last. Is the chart for selecting which steroid is in low dose, medium dose, high dose. Most commonly, you are using budesonide. In low dose, budesonide is 200 to 400. Is low dose in per day combination, microgram. For medium dose is 400 to 800. For higher dose, it is more than 800. You should try to use in between 200 to 400 microgram is low dose to minimize the side effect of inhaled corticosteroid. Second most combination we are using is fluticasone in MDI and DPI. For fluticasone is the medium low dose is 200 to 250, and for medium is 250 to 500. For higher is more than 500 is higher. These are two inhaled corticosteroids we are most commonly used, budesonide and fluticasone propionate. For Gina also stated the role of fraction expirated nitric oxide in asthmatic patient. FeNO is higher in many patients with type 2 high asthma or IL-13 pathway, but is also elevated in non-asthma condition with type 2 inhalation like eosinophilic bronchitis, atopy, allergic rhinitis, or eczema. It is not elevated in T2 low asthma, can support a diagnosis of T2 high asthma, but cannot rule out in or rule out asthma. Factors affecting FeNO, it is lower during bronchoconstriction, lower in early allergic response, lower in smokers. Relationship other type 2 markers is last in obesity. In most patients with asthma, FeNO decreases when ICS continuing treatment is started, adherence increases. If FeNO is level initially high, when we are using inhaled corticosteroid regularly, its level also decreases. So we can also assess the treatment response by FeNO level. Main role remains in helping to guide treatment decisions, basically in moderate to severe asthma. We can also use FeNO as a guide to the biological therapy. Second is the allergen immunotherapy. Gina also stated that allergen immunotherapy may be considered as add-on therapy for adults and children with asthma who have clinically significant sensitization to aeroallergens. The only intervention with both an immune modifying effect and long-term efficacy on the allergic response. Most evidence is for house dust mite and grass pollen in patients with allergic rhinitis. Two studies also suggest asthma comparing immunotherapy with pharmacological therapy are reporting standardized asthma outcome is exacerbation. There are two types of immunotherapy: subcutaneous immunotherapy and sublingual immunotherapy. Both are available. It is for the difficult to control asthma, same action plan. Other changes in GINA is cough variant asthma. Cough variant asthma is another entity. It is common in some countries, especially in our countries also it is very common. Spirometry is normal, diagnosed with bronchial provocation test. Treatment is same as asthma with inhaled corticosteroid. Sometimes patients come to us only for symptom with cough, persistent cough, dry, hacking, especially night cough. And when there is, we are already excluded other history of cough like drug-induced cough, it is level-test cough variant asthma. Treatment will be same with the inhaled corticosteroid. Bronchiolitis responsiveness proposed by ERS ATS technical committee to change criteria from an increase from baseline in FeV1 or FEC by more than 1200 or more than 200, as we seen in the previous slide, this parameter slide. Montelukast leukotriene receptor antagonist is considered. There is constant advice throughout GINA to advise patient caregiver about potential neuropsychiatric side effect. Though there is less evident in our clinical practice, but it is recommended we should use judiciously Montelukast to the suicidal tendency in the children and adults. Increased attention in social media. Pulmonary rehabilitation is also very important for the asthma. Oral bronchodilators is usually not preferred in asthma. Salbutamol tablets, syrup, and our oral theophilus are not recommended for asthma. There is slow onset of asthma, onset of action, less effective for symptom relief than inhaled bronchodilators, more adverse effect. They do not treat the air inflammation that is characteristic of asthma. So these are not quite recommended. Home nebulization with salbutamol is associated with their increased risk, so it is also not recommended with only salbutamol nebulization. There is increased risk of severe exacerbation, more emergency visits, there is increased risk of asthma mortality, and there is increased risk of transmission of infection also. SABA by prescribed MDI or special provide quicker relief and less risk. Inhaler choice. Inhaled corticosteroid markedly reduce the risk of asthma and exacerbation and death. Many inhaler types available with different technique. We can use DPI, we can use prescribed MDI, but most of commonly we are using prescribed MDI with special or dry powder inhaler. We can say Dotahaler, Lupihaler, Respihaler, type of brands available for both. Thank you everyone for kind listening. And one more few slides for our sponsor. Supply is our sponsor. There are some few slides for the sponsor. It is basically for inhaler technique that is very important for the any obstructive airway treatment. Only few slides. This adapt to inhalation. So when we are talking about the obstructive airway disease like asthma, COPD, upper airway resistance syndrome, inhalation technique is very important. Inhalation technique as well as choice of inhaler is also very important. This is the only repetition of previous talk. Nuclear inflammation in asthma. Need of inhaler to treat obstructive airway disease because inhalers provide targeted therapy directly reaches on the lungs. Route of administration and time taken for to reach the target site. Advantage of inhaler therapy. Onset is fast. Dose is very less. Dose in the microgram. Basically, we are using in oral it is milligram, but in inhaler using in microgram. It is 1000 times lesser than the oral dose. Side effect is mild or negligible and useful for acute symptoms also. Oral versus inhaler dose can also the type of the oral dose and duration. We require more drugs, more dosage, but inhaler for inhalation is very less dose, only in micrograms. Prevention and prevalence of asthma in India, about 37.8 million asthmatic patients in our country. 6% is children and 2% is adults. India contributes about 11.1% of the global asthma burden and 42% of all global asthma deaths in India. Despite inhaled therapy being increasingly used, 100% asthma patients in India are either uncontrolled or partly controlled. 32% asthma patients in India reported having nighttime symptoms every night. 67% asthma patients in India reported exacerbation in the previous year, and 42% asthma patients in India reported having daytime symptoms every day, and 78% asthma patients in India reported missing work or school in last 1 year. Possible reasons behind this ICS underuse plus SABA overuse. Evidence are underuse of ICS and overuse of SABA. There is only 18% of asthmatic had at least 75% of they covered ICS prescription, and 35% had received no ICS prescription, and 13% has had at least one exacerbation in the previous year. It is sensitization of ourselves also. We should write more ICS containing regimen despite plain salbutamol dose. Same trial, same studies, multiple studies, so same 30 to 18 to 38% patient were prescribed SABA only. Indian stage also said that ICS underuse and SABA overuse. There is consequences of ICS underuse and SABA overuse. Patient adherent to ICS based control is poor to lack of understanding. Underuse ICS manage their symptoms by increasing SABA by reliever use. Underlying inflammation is not managed with SABA. SABA overuse linked with bronchial hypertrophy, leading to severe asthma, and increased SABA overuse linked with more mortality. So we have to promote ICS containing regimen. Same slides. The finding of SABA only overuse is a matter of concern, as SABA overprescription has been linked with severe asthma exacerbation, increased hospitalization, and increased medical costs. Thanks everyone for kind listening. So take home message, we should use ICS containing regimen or ICS containing DPI or FDI for routine asthma use, and we have to increase its dose according to the staging of the patient. Over to chairperson. Thank you, sir.